Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. Delighted to be back with you this beautiful, crisp Thursday morning. One of these days, it's going to turn warm again. It's going to be another week. But in the meantime, we're going to be right here. We're going to try and deliver you all the good news about COVID and all the things you need to know to help make sure you stay safe. Today, we've got a really special guest. Mario Castro's back. He's a division director for pulmonary. He's like the vice chancellor for all research or something like that. What's your official title now? Official title?
Vice chair of clinical translational research.
There you go. I think I may have just offended Maudius, but oh well. What the heck? All right. Well, welcome back. We're going to be talking about some really great research trials going on here and all things around COVID, I suspect. And of course, we're joined by our faithful Hawkeye. How are you doing this morning?
We're doing okay. We have a little bit of a our data stream is a little bit down because we're doing an upgrade to our computer system and our software. But the information that we do have is that we do have just 27 active inpatients in the hospital.
Wow, that's pretty awesome.
8 of those in the ICU and 6 on the ventilator. So the data from last night would show that we still have 47 people in that recovery period. We had 30 active patients yesterday, so 1 or 2 of those may have moved into that recovery period. But nonetheless, it still seems like it's probably under 80 patients total.
I'm thinking the numbers here, if I'm trying to put them together in my head, that those are pretty good numbers for us.
70s, yeah.
Yeah, that's good. And 27, we were at 27 on Monday, I think, or something.
Yeah.
So we're hovering now in the 25 to 35 range. We're at a new plateau.
Yeah.
I like it. I like the numbers continuing to drop. I like to watch that rolling 7-day average in Kansas City. I'm watching that number drop.
Yep,
I mean,
absolutely.
those are all the right signs, and I think it's got to be a combination of masking along with better behavior that people are doing and vaccination. And let's be honest, there is a percentage of the population who has had COVID now and might have some protection.
There is some immunity, but I agree with you. I think it's that behavioral. This is a behavioral disease at this point. Now, we know that there are patients who unfortunately don't do anything wrong. Have really been healthy throughout this, who inadvertently get it. But it's a lot of behaviors, and it has been historically behaviors, meeting in those large groups, not masking. Hays is doing well too. They are at an equilibrium, about 17 to 19. They currently have 19 inpatients with 9 of those active and 10 in that recovery mode. So.
You know, isn't that funny? Because if you had said to us 6 months ago, okay, you've got 75 or 80 patients in your hospital with COVID, we would have been like, oh my God, it's a 4-alarm fire. And now we're like, oh my gosh, it's so much better.
Yeah.
Well, I'm sure all our relief. It is a relief compared to where we were. So I know we're going to probably have a lot of reporter questions. We'll start with that. I may end up turning to Dr. Castro for some of that too. I'm going to bet there's going to be questions about masking and therapy. So let's just see what's going on with the reporters first.
Hey, good morning, Cody Holyoke, Channel 9.
Hi, Cody. Live long and prosper, Cody.
And make it so, Dr. Stites. So as we're looking at the CDC quarantine guidelines that just came out saying people with their second dose of the vaccine don't need to quarantine, what was interesting, and I'm just curious about this, was built in there, was that they don't need to quarantine within 3 months of having their last dose. I'm curious if that 3-month figure points to uncertainty on how long the vaccine protects you. I've been getting a couple of viewer questions about that as well.
I think that's exactly what it's saying.
Yeah.
What do you think?
Absolutely, it does. I think that's also, they wanted to try to be consistent, although I'm not sure about the quarantine with people who've had COVID infection.
And then you're exposed again.
Correct.
Yep.
Because they have always used that 90-day mark, really. But even in those instances, I don't believe the quarantine has changed from other people. But certainly with these new quarantine guidelines or this new quarantine guidance, yes, if you are 2 weeks after your second dose, where then you have gotten maximal or optimal immunity, and you are less than 3 months or 90 days from that time point, then if you are exposed to somebody with COVID-19, you don't need to quarantine, but you need to continue to watch for symptoms.
Yeah, and just to say, I think it is just tracking with what they've said for if you've already had COVID. Yet there is data out there suggesting that you have really high titers of COVID antibodies after having it for 8. The last one I saw was 8 months. That may have been updated since then. That was about a month and a half ago. So if that's true, then you probably have immunity for a lot longer than 3 months. I think they're just trying to be conservative. Don't you guys both think?
I would agree.
I think so. I think the caveat I would say is that in the studies, we excluded people that were immunosuppressed, that had cancer and other things. When you're talking about these recommendations and you potentially have a chance that you're not developing adequate antibodies after that second, you should probably continue to quarantine.
There you go.
Yeah.
Well, and that also may mean people who are older, although I'm not quite that old yet. Sorry about that. But I think I was over 65. I'm not at that threshold yet.
Yeah, I mean, my concern is that will just cause more confusion. Like, you have to think back, when was my second dose? So I don't know.
So I think in summary, we're saying they said it need to be consistent with guidelines because there's so much we don't know. Stick with it. We're still building the airplane while we fly it. And at the meantime, we'll know more in 2 weeks. But I think that's the current.
Yeah, and I knew Dr. Fauci has really said in the public that he would like things to get back to normal, and he does envision a time when we can move in an expedited way towards normal because of vaccination. So this might just be one more step towards that.
Yep. Okay. Other questions?
Hi, this is Charlie Keegan from 41 Action News. Good morning.
Hey, Charlie. Good morning.
Good morning. I have a slightly off-topic question for our pulmonologist there on the panel, Dr. Castro. It's awfully cold outside, and I've seen people out exercising and running and just being outside. What risks, if any, should folks be aware of when they're out for a prolonged time breathing such cold, dry air?
Well, this is a great question because not only is, not like myself, by the way, Charlie Mario, a board-certified pulmonologist, but he's an asthma specialist, which I think is what the cold air is really going to be a concern about.
Sure. Well, obviously, be careful with the ice and the slippery conditions. That's the number one thing for exercising out there. But yes, cold air is definitely a trigger for our patients with respiratory disease, in particular asthma, where you have that heightened sensitivity. We encourage our patients, though, to keep active. And that's the number one thing, because we know that lack of exercise and so on is detrimental to your health as well. So, some patients will just wear a scarf and kind of rebreathe and warm the air that way, which is adequate to protect against exercise-induced bronchospasm. Another option is, exercise indoors. So, there are ways around this to deal with the extreme cold, and hopefully it'll be beyond us in a week or so.
I remember when I was a younger man, maybe much younger, actually, far younger. I would go out, and when I was in track at high school or whatever, and I would try and exercise when it was around 10 degrees, and I'd try to run and do all that stuff. And I ended up coughing afterwards for a while. What does that mean? Because I think a lot of people experience that, Mario.
Yeah, cough is definitely one of the number one symptoms, and I think it's because that windpipe, that airway, is drying during that exercise, and it elicits that cough reflux. The one thing we do recommend, and I don't know if you did this or not, but is pre-medicate. So we tell our patients to pre-medicate somewhere between 2 to 4 puffs with their albuterol rescue inhaler.
Yeah.
Open up those windpipes, try to prevent that. But yeah, it can be quite bothersome, especially right after you've exercised, and that pre-medication and adequate treatment control of the underlying disease is really the mainstays of treatment.
There you go. All right. Other questions? Excellent. All right. Dr. Castro, you're here to talk about a couple of more exciting trials around us. But before we get there, what's the latest from your standpoint on the AstraZeneca vaccine and the trial here in the U.S.?
Yeah, so we've completed enrollment. We're in the follow-up phase for the AstraZeneca vaccine trial, and we enrolled over 32,000 individuals across that. Here in the Kansas City and the KU region, including all the way down to Wichita, we enrolled 20% African Americans. We enrolled 18% Hispanics. 30% were over age 65. So we're really happy that people participated here in the way that we needed to in order to really understand how does this vaccine work in all those groups. We don't have any data yet. As you know from the FDA guidance, 50% of the participants have to have at least 2 months follow-up. And so we're in that follow-up phase right now. We're eagerly awaiting those results. I suspect, we won't hear anything really in terms of going to the FDA till March. So we're still a little ways out.
Okay, well, good deal. Well, good luck. I hope that's going to be good news for us.
Yep.
So you've also talked about 2 monoclonal antibody therapy trials. How are those going?
So the monoclonal antibody therapy we talked about last time here was called BRIE-2, which is a mixture of 2 monoclonal antibodies, similar to the Regeneron cocktail. The main difference with this BRIE monoclonal antibody infusion was it had a little bit of a variant there that gave it a longer effect. And so we're testing that. We're about to complete enrollment on that and now shift to what we're going to talk about today, which is 4 new treatments. That we'll see. We enrolled over 24 patients here in that phase with the Lilly and now the Bree monoclonal antibodies. And we're, seeing some good results from it. We're blinded, so we don't know for sure. But when patients call us the next day and say, hey, my COVID symptoms went away, I can smell now.
I like that plan.
That is encouraging to me as a physician that's treated a lot of these patients, and you don't see those kind of 24-hour turnaround.
Not from placebo.
No.
It's like on the cystic fibrosis trials, we put people on Trikafta. It was not hard to figure out who got the drugs.
Yeah.
They're coming back, I feel like a new person. Yeah. Okay, we know which drug you got. Okay, so tell us about the trials you're enrolling on now. I'm pretty excited about some of this stuff. I hope somebody got my fingers crossed.
Yeah, no, I think the exciting part about this is we're now opening up to everybody that is COVID positive as an outpatient, and just need to contact Luigi at 588-4022. And you have to be an adult, 18 and older, to participate in the trial. And there are a few other exclusions, but we're much broader now in terms of allowing individuals to come in. Now, the reason is we're trying to test a broader range of therapies. And these 4 new therapies that we've introduced is a brand new monoclonal antibody from AstraZeneca that can be infused or injected. So potentially you could, if this works, you could go to your doctor's office with COVID, get 2 injections, and you'd be, potentially treated that way, as opposed to right now going to an infusion center. The third treatment is looking at a nebulized treatment. So this is interferon, which is a molecule we know is important to fight off viruses. You could get a nebulized treatment, go home, take this nebulizer with you, and treat yourself over a week in quarantine. Great potential there. The fourth treatment is an oral pill, which
Tamiflu, I'm ready.
which is the most exciting, is that potentially your doctor could prescribe you an oral pill. Now, this pill you do have to take 4 times a day, and we all know that we're not very good at taking anything 4 times a day, but, when you're really sick with COVID and you're in quarantine, you have a lot to think about, and hopefully you would be compliant with that. But all 4 of these are going to be tested. We don't know if they work yet. Please participate in the study to help us figure this out if we can get beyond this curve in terms of treatment, because the vaccines will get there, but we're always going to have COVID-19 or some variant of coronavirus, and we need to have new treatments. We just have too few treatments available for these viral infections.
I think that's at the heart of this, and so I'm so appreciative that you're here, that you're bringing that kind of thing going on. So you mentioned why we need to continue to do it. Who's eligible to participate in these trials?
So we're looking at anybody that has a positive COVID test. We need confirmation of that, 18 and above, and then we do exclude some individuals that have a heightened sensitivity to anything that we potentially going to use. For example, if you have a skin disorder and we're giving you an injection, well, we're going to exclude those patients. Each one of these treatments have very specific criteria in terms of who's going to be excluded. For example, the nebulized treatment has some very specific criteria of patients that will potentially have a sensitivity to that medication, as well as the oral medication. So I'm not going to go into too much of that detail in terms of exactly who's excluded, but I would just encourage folks to, contact Luigi at 588-4022, area code 913, and we'll go through that list. We'll go through it over the phone. You don't have to come in. We'll just go over that with you on the phone and see if you would be eligible or not. These are treatments that have been around. We've been studying them for a while, and they've been repurposed. They look like they may work for COVID-19, and so we have a fair amount of safety data behind that, but certainly we're going to learn a lot from this study.
Well, exciting that you're here, exciting that those studies are going on here at KU, and I'm excited that you guys are doing such a great job with enrollment, because you've really enrolled a lot of folks, whether it would be in the AstraZeneca trial, the monoclonal antibody trial, or some of the others. So
we have a great team of coordinators and folks in cooperation across all the venues of KU. I mean, we're recruiting all the way across the state line and with our partners across the state line, And that's been great because, we need to get beyond this, and working together is the way to do it.
So, one thing that may confuse everybody is interferon sounds a little like ivermectin. Can you guys help distinguish between those two things? And I know they're really completely two different drugs, but for a lot of folks, that can be a confusing thing. So,
and we do get a lot of questions about that.
I know.
Ivermectin.
So tell me about how does interferon differ from ivermectin? You two, one of you picked that up.
Well, ivermectin is it's a produced substance. It's made by man, essentially. It is a anti-parasitic drug. It has no role right now in treating COVID. So the NIH guidelines, their initial guidelines came out and said it's not recommended. Now they say we can't recommend for or against it due to lack of data. Overall, the initial studies also, if you're doing pharmacodynamics and pharmacokinetics, the amount really of ivermectin that you would need to put into your body to be effective would be quite toxic. So those are pharmacologic studies, not necessarily in vitro or clinical studies. So right now we don't use ivermectin. Interferon is a substance that you make, just as Dr. Castro said, as an antiviral substance in your body to help that antiviral immune process. We know that SARS-CoV-2 is able to decrease that initial interferon response. So if you can give that, especially early enough in disease, you may get ahead of the decreased interferon response and start that overall innate antiviral response quicker than just with natural infection.
Okay. Anything else?
Yeah, the thing I would add that makes this trial different is it's starting early in the disease process.
Yes.
Right. So what we've learned is a lot of things that we've tried so far in the hospital have not worked, unfortunately. And it's because the disease process got triggered, far before, any of these medications could work. And by starting early, when you've, within that first 48, 72 hours after you start to develop symptoms, we can get ahead of this viral replication, potentially with these treatments, and stop it from, causing the respiratory disease, stop it from causing the clots in the vascular system, the neurologic effects. Those are all very important endpoints because once that happens, we don't have anything right now to reverse that.
Okay, there you go. Well, Jill, let's see what questions are out there today.
Okay, well, so we're going to get a little international today, and I'm going to start with Jeff and Andrew, who are writing to us from the UK, and they're talking about this at-home study using a nebulizer with interferon, and the question is it the same study? Are we all part of this big global effort? They also talk about, they thought we were a little bit slow getting going, and they want to know why that is.
Sure.
Okay, Mario.
So the interferon beta nebulized treatment is produced by a company called Synergen. Synergen has been launching a trial outside of the U.S. before Active 2 adopted it. Active 2, the network within the U.S., is an adaptive trial design. So it looks at something that's maybe promising out there and it says, well, let's go ahead and study it here in the U.S. And that's exactly what happened with the interferon. And so maybe, we are a little slow in the uptake, but I would say that, it's appropriately so. We need to look at the preliminary evidence. The nice thing about this interferon beta, we've actually have been studying it for a number of years for patients with asthma, and have shown that patients with asthma have, as Akai mentioned, a decreased ability to produce your own interferon in your body. And so we were curious, could you give this to somebody that has asthma and prevent them during the peak viral season from having an exacerbation, and actually showed a small effect in patients that had severe asthma. So we have the preliminary data, at least, to move this forward in a much larger study, and that's what Active 2 is going to do.
And I think to add on to that, just as you said, a lot of these things have been studied in the past. We know that interferons have been studied. It was part of the treatment regimen for hepatitis C for the longest time. So these interferons are not new. There has been a lot of studies on different interferons because there are different interferons. So just as the mRNA is not necessarily a new platform or new technology, it has been around. Same thing with the interferons.
And we may be a little slower on interferon, but can we point out that we've helped lead vaccine development across the world?
That's right. We pushed it forward.
There you go.
And Jeff has a follow-up question to this, and it is, so how quickly do we move to the phases? How quickly do you apply for an EUA here in the United States?
So active 2,
especially your oral pill. That's what I want.
I think that's the one he's interested in as
Camostat.
well. Yes.
So the way we set up this trial was we enroll 100 individuals in each arm. Once we get that and we have, that's phase 2. Once we have that preliminary data and results from that, then the company will apply for an EUA to the FDA. That same time, we are moving forward after we complete that phase 2 to phase 3, and that's when we're going to have 1,000 patients in each of those arms to figure that out. I think that, a lot of this information, when we have seen the results from phase 2, we have to be very cautious in terms of when you get in a broader population, how safe is it, how effective is it in a broader population. So it's really key to have that phase 3 data, just like we're doing right now with the vaccines. And that ultimately will dictate whether or not the FDA will approve it for an EUA. So, we're probably, we'll enroll fast for the study. So contact Luigi fast, but it is something that I think will be promising. If it is effective, we should have that, potentially by later this spring.
Yeah. And Angel, I hope I'm saying the name right. Could you clarify again who's eligible, and are the studies happening right now? Do you want people to call you right now?
Sure. We're ready to take your call at 588-4022. Eligible or 18 and above, you have to have a positive COVID test. That COVID test needs to have been positive within the last 7 days. So we want that test not to be 2 weeks ago that you're calling us, but it has to be within the last 7 days, and you have to have active symptoms at the time that you get randomized. So those are key entry criteria as we screen patients over the phone. And certainly if you are having active symptoms, you're an adult, and you potentially could participate in this trial, please call us.
And Cindy says if it's been in the UK and you kind of noticed it, are there side effects?
Sure. With anything nebulized or inhaled, you could always have some bronchospasm from it. And so that is
tightening of the airway.
Yeah, tightening of the airway. And so we're going to watch for that. And certainly we use the nebulized treatments all the time, every day, and our patients are very used to using that with respiratory disease. So that's something that we can deal with, and I think we will appropriately make sure that you're comfortable with that nebulizer. It is a different gadget. It's not the one that we typically use in our practice, but this allows you to inhale the medication and not expire into the outside environment. So it's kind of like a one-way nebulizer in that regard. And you can imagine if you have COVID, you don't want to be spreading this virus in your environment. So this is important that you get trained in how to use this nebulizer to deliver the interferon.
Diane wants to know, is there any point in trying monoclonal antibodies on long haulers? Any progress being made for them, doctor?
Nope. Yeah, at this point, with the long haulers, which we're getting geared up to try to understand what is the disease process once you have had COVID and you're on the recovery phase and have persistent symptoms. At this point, the monoclonal antibodies do not appear to be effective in there. And in fact, as we know, when we test these patients, they don't have the virus present anymore, right? So the monoclonal antibody wouldn't really make sense that it would work in that situation.
Yeah, the monoclonal antibodies really are only effective for people with active viral replication, and they are most effective in people that are early in disease with that early viral replication. The long haulers, that tends to be more of a consequence of that immune dysregulation and that inflammatory state. All the collateral damage that is done by your immune system in your body, such as the shortness of breath and the cough, and the lung infiltrates, the changes in your lung. We don't really know the mechanism of the fatigue or the brain fog yet, but it's probably similar to that as well. It's a consequence of that immune dysregulation.
And just to say, at that point, you have your own antibodies, so giving yourself additional antibodies
Correct,
really isn't going to make a difference. That's what monoclonal is. It's really because you haven't made antibodies, we're going to give you those antibodies until your body makes the antibodies. Once you start making them, there's no more point for it.
Isaac wants to know, how long is it going to be before I can just pop into the pharmacy and get these anti-COVID pills? And I want to point out.
Okay, Castro, let's go with that one.
I want to point out that Isaac was asking this question way back in the summer. I mean, this guy has been looking down the road for this
He's
for a
been
long
listening.
time.
Yeah, well, Isaac, I can tell you this is a study, and we don't know if it's going to work or not, and so I don't have that crystal ball. Maybe Steve does.
No, I'm just saying, if you knew it was going to work, there wouldn't be a study.
Exactly.
So the problem is we don't know, and so it's right. But let's take a different track. Let's say the study works.
Sure.
Data looks great. How long then?
Yeah, so, the active trial network was really set up to be a quick response, to allow us to study things in an adaptive nature and really get an answer quickly to the FDA so they can review the data. And that happened with the Regeneron antibody, and it happened with the Lilly monoclonal antibody. We were able to study that very quickly, and it was approved, one in November and one in December. So, I suspect that if we are able to get this enrolled, by March, April, that we may have this, if it works completely, maybe by the summer. But it's likely going to be something that's going to take us some time, and this may not be the first answer. We may need to study several different medications to get us a home run.
Okay.
Anil asks, anyone...
Hi, Anil. Welcome back.
Anyone see the Pulmocort study showing a 90% reduction in hospitalization rate?
I know you had to look at that.
I'm not familiar with
Yeah,
what's...
I saw it, and I think it was, I thought it was actually discredited later because there was some uncertainty about some of the dosing and how people got enrolled. There wasn't really a fair study. So I think we'll have a more full answer to that for you tomorrow, Neil. But I did see it, and I did look at it. I don't remember all the details about it, to be honest with you. That was about a week ago or 10 days ago. And what I recall is that data was a little questionable. It may have begged for more information to be found, and it may need to follow up. But we'll be smarter tomorrow.
Yep.
Okay, it says, Craig writes, me and my family are getting the Pfizer vaccine on March 1st.
All right.
And then my kids go back to school the day we get our second jab. Will we have some protection, or if they happen to bring home COVID, will we get really sick?
Actually, you do get protection, depending on how soon your kids bring it back, because it depends on how fast. We know that after about a couple of weeks, you begin to do see an improvement in outcomes and response.
Yeah, we know in the early Moderna and Pfizer studies that really after about 12 days, you can see a separation of the curves of the people that just got the placebo, which is not active vaccine, or the vaccine. You can start to see that those people that actually got the vaccine had a lower rate of actually getting the disease, and that's after 12 days. We know your immunity is not maximal until about 2 weeks after that second dose, but you will start to gain some of that immunity. We just don't want to say that you're fully protected. So if you are getting the first dose and then the second dose, I think the day that your kids leave for school or take your kids to school, you should probably be more protected, but you still need to continue to do the masking and the distancing as well, and that is fully recommended for anybody who gets the vaccine.
Caitlin lives in Missouri. She says, my asthma does not qualify me for an earlier tier of the vaccine. I am in the last phase. Why is asthma not an at-risk condition when SARS and COVID-2 are respiratory
That's
issues?
a great question. It probably has to do with how stable that asthma is.
Yeah, so it's a great question, and we know now that asthma and other respiratory diseases certainly at this point doesn't appear to increase your risk of getting COVID. And what we do know is certainly if you have underlying lung disease and you get COVID, it can make it much worse. But it doesn't hit the same level that age does and some of these other things. And so you're correct. It's, and at least in the Kansas plan, it's in the later phase. It's in that phase 3 that they would be eligible. And I just looked last night at the mortality curves from the CDC, and it's clear. When you look at age, you get older, that mortality goes up. You don't see that with conditions like asthma. And so, yeah, I wish all my asthma patients could get
Yeah.
it tomorrow, but it is, in limited resources, it's something that's going to have to wait till that next phase.
Yeah, I think that's exactly it. We thought these people with lung disease, including asthma, including children as well, were at higher risk. But when you look at it, it's really the age, the obesity, what class of, morbid obesity are you? What is your BMI? Diabetes, heart disease, those things seem to play a much larger role as far as comorbidities and risk of severe disease and death than asthma does.
And you would think, because even in some of the transplant patient populations and in CF population, I know that the outcomes aren't terrible unless you have more severe advanced disease. And there may be some, we've actually transplanted patients with active COVID because we didn't know they had COVID at the time. We had done a test, then we do another test, and it turns out they were COVID at the time of transplant. Actually, those folks have done okay, which you would think, oh, that shouldn't happen because we suppress the heck out of them. But we should talk. We can talk a little bit about that sometime with one of our transplant docs down here. It'd be a fun conversation, I think, around
Yeah,
COVID.
yeah, no, it is interesting. We're starting to learn a little bit more about transplantation in this COVID era, and I know across the U.S. There have been at least 36 transplantations done post-COVID, and I'm not sure about whether or not they're active COVID or not, but I think they're probably farther along in the recovery phase. But it is something that I think, unfortunately, is probably the only opportunity for those patients to make it through. And so it is something that we're considering, I think, in terms of if you have really severe disease, whether or not transplantation would be a lung transplantation.
I've known some folks who have had lung transplants,
Yep.
post-transplant, and
Yep.
did okay.
Joanne says the CDC says that you need to double mask against the new variant. She wants to know if that's true, and if so, if you put a filter inside of a mask, is that the same as double masking?
Okay, I think the question about this will be fun because the answer isn't the actual mask itself, it's the leak around the mask. So putting a filter inside the mask doesn't prevent the leak around the mask. The point of double masking is really to create two masks to help add more seal around your airway.
Yeah, absolutely. The CDC has not changed their guidance on masking, not double masking. What she's referring to is an MMWR, which is a CDC publication and a very good study that looked at double masking. But what they looked at was just a surgical mask with a cotton mask over it, or a surgical mask with a knot tied near the edges so that it fits better, just as you were talking about.
I made a couple of those this morning, and what I've learned is, first of all, my fingers are still nimble enough to tie that little double knot, but the real goal with the double knot is to try to find a way to seal it. And the only problem is you do cause a little bit of bowing right there at the edge of the mask.
Yeah.
There you go. There's my double knot right there, or extra knot right there, and then you go, you're trying to make sure it stays as tight as possible around your face. You got to reposition it, do all that, and then of course you got to clean your hands.
Yeah, and I would encourage everybody to go to this publication. Again, it's freely available on the cdc.gov website. Even Rachel Walensky, the head of the CDC, yesterday said it's not really changing any guidance, but what we want to do is make that fit better. And that's what the cotton mask over the surgical mask does, and that's what those knots around the ear loops do as well. It should be noted the caveats that the authors mentioned in the article as well. They did not test surgical mask over surgical mask or cotton mask over cotton mask. What they tested was surgical mask under the cotton mask. And again, the main point of that is really just to get the fit much better. So I think hopefully that will clear it up. We still look for more guidance, but right now the CDC otherwise hasn't changed their guidance to wear double masks, other than to make sure the fit of your masks is improved and as best as possible.
And you guys can comment. One of the issues with a variant is it's more infectious per cloud of particle.
Yeah.
We haven't talked about cloud or breath cloud for a while. Than the SARS-CoV-2 that doesn't have the UK variant in it. And so what that means is it takes less virus to make you sick.
Yeah.
And so as a result, the more you can shield out, the better, the safer you are. And I think that's really the key here.
Yeah, that's it. We have to understand the droplets, or the respiratory droplets that you exhale and put into the environment, have not changed, have not decreased in size. The virus itself has not decreased in size and can get through the filters better. What is important is, just as you said, it's probably due to the spike protein and the changes in that, it's just able to better bind to the receptors on your respiratory tract. And so that's what it is. If you can create that fit to decrease the amount of any droplets that would get in or around the mask, that is the main goal there.
Okay, Sue and a lot of people have questions today on the thread about the vaccine and transmission. Is there any update on that if I get my vaccine, and they talk about Pfizer a little bit, does that mean that I'm not a carrier, that I can't be contagious?
I think what they're saying is that after you get the vaccine, there is some early evidence that it may cut viral transmission by 2/3. I think that was actually in the AstraZeneca trial, though, right? I think it wasn't in one of the other trials. I haven't seen that regarding Pfizer yet. Comments, guys?
Well, I would say that the number one take-home story is that even after your vaccine, you still got a mask, and because we are not sure how much it's going to the vaccine is actually going to allow you to have neutralization of the virus, and so the virus, you could potentially carry the virus and spread it, and so even
Which is true for influenza, just to say that's how influenza works.
That's true. That's true with influenza as well. So we're still going, at this point, going to need to mask and be socially distancing and washing our hands. I do believe that we need better data, and we're just still getting that data right now on all the vaccines that are coming out, the Pfizer, the Moderna, the Johnson & Johnson, and the AstraZeneca vaccines. We need to find out, are they interfering with viral replication? And then even after we figured that out, then we're going to still be faced with the variants and understanding whether or not they will interfere with replication of the variants. But at this point, I'm not convinced by any of the vaccine data that I would be feeling safe to recommend that to my patients.
Yeah, and I may not be remembering this exactly correctly, but I think there was a question to Dr. Fauci about a woman who wanted to play bridge with her girlfriends again and get back together with her girlfriends. They were all in that phase 2, so they were all vaccinated. And she said, when can we do that? And to paraphrase his statement, and we alluded to this earlier in the broadcast, those guidance points may be coming because we want to get life back to normal as much as possible. So that was the impetus of that. But right now, we still have to remember that even if you do get vaccinated and you're 2 weeks from that second dose, you still need to continue to mask and stay distance and not meet in large gatherings. Keep your bubble small as much as possible. But they are looking to change and modify that guidance.
Melody has a question about Melody has a question about third-party exposure. In this case, A, who was sick and didn't know it, was around B, closer than 6 feet apart, no masks. B goes home. Is B going to make Melody sick?
Okay. What do you think, Hawk?
What's the danger?
We know household transmission, if that person is positive, we know household transmission can be anywhere from 15% to 50%. I think you can start isolating or quarantining as much as possible in the household. Wearing masks in the household will cut down on that as well, as soon as possible after that exposure is known. And I think adults have a higher chance of spreading it to other people in the household than do children as well, and those come from some of the school-age children studies. So I think there's a good possibility. As of right now, person C would just be a contact of a contact, but I think there is a reasonable risk that person B could have the disease and easily spread it to person
Yeah, I think
C
that's the key, because contacts are contacts we don't trace.
Correct.
It's the contact of the source, and I think that because you're a contact of a contact, the percentages go down. So, but it is still, as Dr. Hawk said, it is still a very valid concern, and you ought to take the safety measures, especially if you have any underlying disease, especially if you're over a certain age. Not necessarily my age, well, probably my age, and something like that. Then you have to take more. You have to take more precaution.
Oh my gosh, these questions
One more
are so
question.
good. Okay, but I'm going to make it a split one with
Of course you
Dean
are.
and with Mary. It's my way of squeezing
That's
in
two
an extra
questions.
question. I know,
Yeah,
right?
I got you.
So Dean wants to know if you can call the inhaler. He just says that sounds so exciting. Is it going to be a game changer? And Mary, on the other hand, is worried that if these new drug treatments could create destructive aspects on your immune system response.
Okay, so could they hurt you?
Yeah, well, I mean, the
Long
reason we're just studying the study is we're looking at side effects, and we're going to look at the side effects in a controlled fashion in order to figure this out, what those effects are. The only thing I would say is that at least with the nebulized medication, the interferon, and with the oral medication, the Camostat, they've been around. We've had them for over a decade. The Camostat has actually been around since the 1980s. And so...
Don't make that sound so old, Kevin.
So, you know, it is something that we have a lot of safety data available on it. At this point, it doesn't appear to modify your immune system in a way that would be deleterious. And I think that's the key for that, is that when you nebulize the interferon, you're getting it down into the lungs, less systemically across your entire body as you would from an injection or an oral medication. And therefore, you're localizing where that immune response is, where the virus is replicating. And so that's the hope, is if we can get it to where the action needs to be, that it would be effective in that regard. So that's the, you know, answer to the immune response part of this. Whether or not it is going to be the home run, I can't speculate right now. I would say that the preliminary data looks good enough for us to move forward in this phase 2 trial. But phase 2 trials are called phase 2 for a reason. You test them in smaller populations. You look at the data before you go to larger populations, because we just don't have enough data on it.
All right. Anything else?
Well said.
All right. So, hey, just a quick thing about tomorrow. It's Amanda Cackler back with us to help answer your very hard questions. I think Jill will be running the show tomorrow. I have a program.
Maybe.
I think Dr. Wild is too. So we'll see
And
how
I
that
can
goes.
ask all the questions I want.
Yes, you can. All right. And let's have final thoughts today from our guest, Dr. Castro.
Well, I just want to reach out there again, give you the number 913-588-4022. Thank you for having me on here. And really, one part we didn't mention is that we're all in this together. You know, studies really help us move this forward and get over the pandemic. You know, I'm frustrated. I was on consults last week and seen a lot of my COVID patients, and really they're saying, Dr. Castro, when can I get better? And I said, well, I'm sorry, this is in for weeks into recovering from this. So help us get ahead of that by treating this, I believe, in a mild form when you're out there early on in the infection, in that first window of opportunity, in that 48, 72 hours. I think that we have a chance to get ahead.
Thank you. And thanks for being here. You are welcome back anytime. When is he coming back again?
I'm going to talk to you about that after the update.
Yeah, I think there were good questions today. There's been a lot of new information about vaccines, about what to do after you get vaccinated, and quarantine, and especially about masks. That's important for everybody. We know the mask culture continues to improve. Again, right now, it started with Dr. Fauci saying it probably makes common sense that double masking would help and be more effective as a barrier and a protection to the wearer as well. Right now, the best data is with that MMWR study that shows it's a surgical mask under a cloth mask. Certainly, I think if you are at home and you wanted to wear 2 cloth masks, that's fine. Just understand there's no specific guidance or direction from the CDC to do that. The thing to remember is improved fit of the mask, and that will help reduce transmission as much as possible. But as new guidance comes out, we'll certainly continue to keep you abreast of all the new information.
So before we have our closing thoughts with Dr. David Smith, who did a great job with us on Monday, this thought: faith, hope, science. You hear me talk about that a lot. Faith in each other, faith in doing the right thing and taking care of each other, and for me, faith in God, combined with hope, which helps us wait. It helps us get through this pandemic. And then science, which rewards our faith and hope by bringing us new therapy. We're so happy you were here today. Thank you for helping to be here and talking about and advancing the science. And remember that until then, those rules of infection control, washing your hands, wearing a mask, maybe 2, keeping your distance, don't go out if you're sick, cough into your elbow, and gosh darn it, get the vaccine when it's offered. Those things will keep you safe until the science is here to make us safer. Thanks for being with us today, and remember, there's still no place like home. Let's hear the final words from David Smith.
Outdoor sports are safer than indoor, but indoor sports can be just as safe. It's interesting, they used to categorize sports as to high risk, medium, and low. And I used to say, don't do that, because you can take a low risk sport and make it high if you don't do the right things. Right. You can take a high risk sport and make it low. So let's not categorize. So now that's a thing of the past. We're saying all risk, you can be on equal playing field. How to reduce the risk for each of those sports. We realize that the infection is not on the field in training and in competition. It's in their social circles. That's been made very clear, that it's equivocal on the field and in the community. And therefore, we need to keep being careful with athletes and keep them out of these social circles and use those pillars of infection control. Even in track. Track is a sport, we've got boys and girls competing at the same time. It's in a big outdoor venue, but, they like to congregate. They like to socialize. They like to eat snacks together. And we're telling them, you just got to keep being careful about that. Graduated return to play shows that if you take someone who's been positive and you can start them out with step one, let them start exercising at a low level, less than 70% of their maximum heart rate, and do that for 15 minutes and see how they feel. If they feel good, you can do another day of that, maybe increase the time a little bit. If they get past that, no symptoms, feeling good, then the next step, step 3, would be adding some resistance training, a little higher level, getting up to 80% of maximum heart rate. And again, ask them, how are they feeling? Are they tired, chest pain, dizzy, short of breath, coughing, anything that would be a red flag that we need to back them down and maybe get more testing. The step 4 is when you add much more. And basically, it's full training, full weights, running hard, 80% of maximum heart rate. And if they get through that, asymptomatic, doing well, advance into step 5. Step 5 is full return to play.